Shirley-Ann Osei-Onomah from the University of Michigan Flint. I'm here with my colleagues Erin Brown and Whitney Brown to share some information on length of stay in hospice care. I will be talking to you about what length of stay is, the history, developments, and the use of the term length of stay in hospice. Whitney will talk to you about measuring and defining length of stay in different hospice settings, and Erin will be talking to you about population health, financial management, and the long tail theory. Hospice care is a unique system which provides clinical and psychosocial services to Medicare beneficiaries who have terminal illnesses or have a life expectancy of less than 6 months. Usually, these are people who are willing to forego curative treatments because they are usually not even responding to them anymore. It is focused on medical care, pain management, emotional and spiritual well-being, and these are tailored to suit a patient's medical needs and wishes. Now, where is hospice care provided? It can be provided at home, in nursing homes, assisted living facilities, inpatient hospitals, and other long-term facilities. Majority of the care occurs in a patient's home, usually involving a family member as the primary caregiver. The primary caregiver makes decisions for the patients when it's appropriate, with hospice staff paying regular visits to the patients for assessments and medical care. Now, there are 4 types of hospice care provided to meet the needs of a patient. We have the routine hospice care, which is the most common type of care. It's when an individual opts to have this care at their own residence. Example, an assisted living facility or a nursing home. General inpatient care is provided to control pain or acute symptom management that may not be achievable in any other setting. So it usually occurs in a Medicare certified hospital, a hospice inpatient facility, or a nursing facility with an available 24-hour on-site nurse to provide direct patient care. Continuous home care, like the general inpatient care, is provided to manage pain and other acute symptoms. However, this is only between 8 to 24 hours. These services are mainly provided by a nurse, but in some cases they can be supplemented by caregivers or hospice aides to maintain the patients during a pain or crisis. Inpatient respite care is temporary care for a patient for a maximum of 5 days in a hospice, hospital, or a long-term facility with sufficient 24-hour nursing personnel to meet patient needs. Although hospice patients may be admitted at any of the 4 levels of care, changes that occur in their health may require a change in the level of care. This paper will clearly outline the definition, history, development, and use of the term length of stay in hospice care, the definition and measurement of length of stay in different settings, including at home, in acute care, in a hospice residence, and in a nursing home, and its unique link to population health and health financing. We will also tackle the long tail theory and its relationship to hospice care. Hospice took shape in the mid-1960s when Dr. Dame Saunders worked with terminally ill patients in the UK. It reached the US after Dr. Elizabeth Ross's book on death and dying was published. In 1972, Dr. Ross testified to the US Senate of Aging on the importance of hospice on final care at home. Through the 1970s, hospice started to form in the US when Connecticut Hospice was founded. The Senate also introduced the first legislation for hospice to become a fully funded program. Now, between 1982 and 1986, hospice was available to all Medicare patients and terminally ill residents of nursing homes. The major change in hospice was under President Clinton's administration when it became accepted into health care as a guaranteed benefit for all American citizens. The Affordable Care Act, hospice, in 2010 was made available to all Medicaid children who were suffering from life-threatening diseases. The length of stay in hospice has changed, as well as the number of hospice patients. The Medicare Payments Advisory Commission's 2017 annual report to Congress reported the increase in average length of stay in hospices in the United States from 53.5 days in 2000 to 86.7 days in 2015. The National Hospice and Palliative Care Organization also reports an increase in the number of patients being serviced from 25,000 in 1982 to 700,000 in 2000 and 1,656,000 in 2014. It is important to calculate the average and median length of stays in hospice care to ensure quality care for Medicare patients and also ensure the proper billing patients.
When a patient chooses to receive hospice, there's a couple different ways that they can receive it. First and foremost, the most popular way is at-home hospice care. About 98% of people who choose hospice choose the at-home setting. For the first 60 days, it's about $187 per day paid by Medicare, and the next 60 days is about $147 also paid by Medicare. Medicare also pays an additional $39 per hour up to 4 hours for any additional things such as a social worker or a registered nurse. And that usually tends to happen the last 7 days of a person's life. We typically see continuous care being provided to a patient who is receiving hospice care at home in the last few weeks or few months of their life. Something that is unique about continuous care at home is that at least 50% of the work has to be performed by a registered nurse, administering whether that be medications, assisting with taking care of them, whether it's diaper changes or anything like that, getting them up to go to the bathroom, anything like that. Something that's also interesting is we also see more agencies starting to pay for continuous care in an at-home setting, like charitable community funds, when insurance and Medicare do not provide or pay for those services. So next we're going to talk about hospice in an acute care setting. Something that is unique about hospice in an acute care setting is that this is more regulated due to hospice care stays being regulated, as we learned previously, first by having 2 sessions of 90 days, followed by an unlimited amount of 60-day sessions, meaning that a patient can stay in hospice in a hospital for 180 days, leave that day, stay 1 day at home, and then come back for 60 days, leave, have 1 day at home, and then come back for another 60 days. The way that hospice in an acute care setting works is they figure it out by the date a patient is administered by minus the date they are. So the next care we're going to discuss is hospice in a residential setting. This service is performed to patients who are usually in the last few days of their life, or they need a very high level of hospice given to them. These hospice settings tend to mimic a personal home, so we see 24-hour visitation given to family members, as well as private rooms and kitchens. The typical stay for a client or a patient receiving hospice in the setting is 5 to 6 days, but they can stay as up to 30 days. Due to this care being such a high demand of care, those who receive hospice in a resident setting, we will typically see the final care we're going to talk about is how hospice can be received in a nursing home. So typically when you think of a nursing home, a lot of people think of someone paying for it, but hospice can cover a certain portion of nursing home stay. Those who receive hospice in the nursing home, it works a lot like how we calculated hospice in acute care. Someone who receives hospice in the nursing home can stay up to 120 days, and the calculation is very similar to the hospice in acute care, with subtracting the days that the client stayed from when they entered to when they left.
Hello, my name is Erin Brown, and I'm going to be talking to you about population health, financial management, and the long-tail theory and how it relates back to hospice care. Population health focuses on improving the health of populations, and palliative care in hospice focuses on improving the quality of life of its patients in hospice care. Often, many aspects of population health are in hospice care, including open communication about end-of-life options and promoting the well-being when faced with life-threatening illnesses. Keeping track of hospice care length of stay will help population health researchers make decisions when looking at the data of quality of care and quality of life while in hospice care. Financial management and hospice go hand in hand. Being cared for in hospice setting will reduce 911 calls, ER visits, and unnecessary hospital visits in the last days or weeks of a person's life. This cuts back on many unnecessary expenses while improving the quality of life during that time. But someone has to pay for those hospice expenses. The U.S. government spent $994 billion in 2012 on Medicaid and Medicare. Most can agree the majority of the increase on spending of these programs is due to the baby boomers reaching the age to start utilizing the programs, along with the longer life expectancy and an increase in chronic illnesses. Now I'm going to talk about the long tail theory and how it applies to hospice care and length of stay. The long tail theory was written and published by Chris Anderson in 2004 in the Wired magazine. The overall theory states that our culture is shifting away from a focus on a small number of popular hits and focusing on a larger number of less popular products.
This is a graph of the long tail theory. The red section represents the more popular products, the ones that you would find on Walmart shelves. But the orange section, the long tail, includes a much larger number of less popular items or products that would not sell enough to be worth putting on Walmart shelves. Today, online vendors have nearly unlimited shelf space, meaning they do not have to worry about selling that specific product in one specific store, but can sell it virtually anywhere in the world. Anderson wrote, "When consumers are offered infinite choice, the true shape of demand is revealed, and it turns out to be less hit-centric than we thought. People gravitate toward niches because they satisfy narrow interests better."
Anderson's theory also applies to hospice care. This red section right here, called the head, represents hospice care in home. This will apply to most hospice patients because that's where they want to spend their last few days or weeks, is in their own home. For the rest of hospice patients that fall into the long tail, this orange part right here, they must receive care in a nursing home, hospital, or hospice facility. These are the small niches that we talked about earlier. They need specialized care for a possible rare illness or constant skilled nursing for shorter or longer length of stays. So to recap, Shirley-Ann talked to you about what the length of stay is, the history, development, and the use of term length of stay in hospice care. And Whitney talked to you about measuring and defining length of stay in different hospice settings. I talked to you about population health, financial management, and the long tail theory. As you can see, hospice is a very unique healthcare system. It is usually given to someone toward the end of their life. Hospice can be performed in many ways, such as in an in-home setting, a residential setting such as a nursing home or assisted living facility, or in a hospice facility. You can receive up to 150 days of continuous care if signed by a healthcare provider, but issues we're starting to see with Medicare recipients and of hospice and other programs is that funding is running out. To prevent this from happening, we are starting to see more of an emphasis put on the end-of-life, palliative care, and discussions by medical staff and family. By putting this emphasis, we can greatly reduce the cost of Medicare costs, while we see more baby boomers needing those services. While hospice or end-of-life doesn't necessarily affect me or my colleagues, researching this topic has made us see the importance of discussing end-of-life care with our loved ones and the options of hospice.